Marc, welcome to the Talking Gut podcast.
Thank you.
Now, I've got a whole range of questions to ask you, but I'm really curious, where did your journey into medicine and then pediatrics begin?
My parents, they divorced when I was, I think, 10 or 11.
Mm-hmm.
And then my father, he remarried again. And his wife gave birth to two boys. And from the first minute I saw these two boys, I was really involved with everything they did. So that was probably the time that I thought, okay, I like to be a pediatrician. So that's when it started. So I started medicine in 81 when I was 20 years of age. And then I did my medicine and then I finished. But in that time, I combined it with my career as a national hockey player. And it is quite difficult to become a pediatrician in the Netherlands because there are not that many places for people to become a pediatrician. So I thought, okay, what can I do? And then one of the pediatric gastroenterologists working here, Jan Terminio, he was a former hockey player as well. And I thought, okay, he might remember my name, or I hoped he would remember my name. So I went into his office and asked him, I want to be a pediatrician, but I don't know how to do this. Do you have some work for me I can do for you, some clinical work or scientific work? And then it all started. And only after 6 months, I started to look at the children with constipation and fecal incontinence. And that's how it started.
It's incredible that you knew from such a young age. In terms of, you've explained pediatrics. Why gastroenterology?
I think this is a coincidence because I wanted to be a pediatrician. I didn't know how to do this. So I walked into this office of this guy who was a gastroenterologist and a former hockey player. And he was working on biofeedback in children with constipation. And he thought, oh, okay, this is a nice idea. We have a lot of children in the Netherlands with constipation too. I like to use this new tool to treat children with constipation, but he didn't have the time to do this. And that was the moment I walked in. So I started from scratch. There was nothing, there were not enough patients, but it was like a gold mine because nobody wants to treat children with constipation because most of the general pediatricians, but especially the pediatric gastroenterologists, don't think it's a very interesting topic. So I had the world for me alone almost.
I'm trying to remember who told me this, but there was a bit of a backlash in terms of with your earlier studies looking at hypnosis and how you single-handedly made hypnosis okay in terms of gut-directed hypnotherapy okay in the Netherlands. Is that correct?
Well, yeah, that's completely true. So it started when I went to a symposium in Nice in France. Mm-hmm. And there I heard Peter Warble, who's a gastroenterologist, talking about hypnotherapy and irritable bowel syndrome. And he showed these unbelievable results. And I didn't believe any word. I thought, okay, this is nothing. I couldn't believe that everybody was cured and that quality of life and everything was better after getting hypnotherapy. And then by coincidence again, I don't know if coincidence exists, but by coincidence, I sat next to him at the dinner and we had a very nice talk. And I asked him, do you think that hypnotherapy would be nice for children as well? And he said, oh, I think it's much better because children, they are not biased and they can handle these exercises. And and then I thought by myself, okay, how do I do my own treatment for these children? What do I have in hand to really evidence-based treat these children? And then I thought by myself, we have nothing. If he shows these results, why shouldn't I try? And I had this cousin who is a hypnotherapist and asked me for years, please send me some patients. I thought she was mad or so. I didn't believe her at all. And I thought by myself, okay, let's try. So I sent her 10 patients, just a pilot. And well, many of these children did very well, and I was fascinated. So I thought by myself, okay, let's do a randomized controlled trial like Peter Warwell did. Nobody wanted to give a grant for this. So I paid it myself. And after 4 or 5 years, we had this incredible result showing that I was able to successfully treat 25% of my patients, whereas this lady who was outside of the hospital and was not using drugs or foods or whatever, she successfully treated these children in 85% of the cases. But then I was really surprised that some of the professors in our hospital thought that I was a fool. I was not very honest, because they thought, okay, these children were randomized, but many children had headache in one group and not headache in the other group. I didn't look at it at all. He was a neurologist. He said that we were biased, that we filled in the questionnaires ourselves. All very, very nasty accusations. So I was surprised that although the results were so good, that so many people didn't like the form of treatment we did, because they said this is not this doesn't belong in academics. And after this trial, we did a large trial which was subsidized by the government. They gave us like 600,000 or 700,000 euro to again look at hypnotherapy, and I think it's the best studies I ever did, because they were so successful, whereas most of the constipation trials are all negative. So, but I'm surprised that people don't like it, because it's called complementary medicine, and that might be one of the weaknesses of hypnotherapy until today, because we don't exactly know how it works. But if you ask parents and patients, then they're very happy with it.
There's a lot of areas of medicine that we're not really sure exactly how things work. How do you explain? I mean, you've done, let's just say the example being, it could be functional abdominal pain, or it could be functional nausea. Let's just say that a lot of the organic, the potential organic factors have been excluded through the diagnostic testing. And it becomes apparent that this is a functional gut disorder, whether it's IBS or whatever. How do you explain functional to parents?
Yeah, well, you know, if they come to our clinic, then it's a little bit more simple, because many children were seen by general pediatricians many times. They did a lot of blood testing. They did sometimes endoscopies. They did X-rays, whatever, and there's no cause for the symptom found. And then I try to explain them that if I give a talk on, for instance, abdominal pain, I'm always a little nervous, and when I'm nervous, I go to the toilet more frequently that day than other. And I'm not mad, I'm not crazy, but that's how the brain and the gut connect. So you can imagine that if you are stressed for school or stressed for anything, that there's a chance that you feel in a different way than somebody who doesn't have this stress. And you know, as you know, many children face a lot of problems at school because it's too difficult or too simple, or they get bullied, or I always tell stories about Facebook, how terrible this is, what children are liked or not liked, or whatever, those TikTok things, which is new. And this has a connection between the brain and the gut. And if you explain it in this way, they can understand it. But I always also will tell about the microbiome, because there is now some evidence that the microbiome in children with abdominal pain is different from that of children without abdominal pain. So the microbiome might be involved, and if you are more relaxed, it might change your microbiome. I don't know if this is true, but this is now the subject of many studies. If the microbiome changes after, for instance, painkillers or relaxation by hypnotherapy or behavior therapy. So if you explain it in this way with drawings, then most of the people really accept it.
In terms of your approach to treating these conditions, let's just say functional abdominal pain again, what's your approach? I mean, there's sort of 3 tiers, isn't there, in terms of there's the medication, and I'm kind of curious about what your thought and take is on that.
Well, it's not an easy question, because so there is no specific guideline. That's one. That's strange, because abdominal pain is the most frequent symptom found in children. compared to any other symptom. So that's strange that you don't want to spend money to develop a guideline. So everybody has his own guideline how to treat these children, and it's the belief of the doctor himself or herself how to start. I always start with the drawing. I reassure the parents, and I explain, like I did, the connection between the brain and the gut. And then the next approach is I always tell the story about a study by Lynn Walker, where she did a water load test, and where she showed that if you compare parents, so the test was as follows: the children had to drink 100 cc of water, and after 1 minute they had to do it again. And there were children with pain, and there were healthy children, and the parents were divided in 3 groups. One group of parents was not able to say anything during the test. One group of parents was able to play a game or do some reading or something, and 1/3 of the parents were able to ask after every 100 cc, do you feel anything? Are you nauseated? Have you pain? And the study clearly shows that if you pay attention to pain, that children indeed have more pain than the other 2 groups. But then it was fascinating that after the study, the parents were taken together, and especially the mothers always told the investigators that they felt really sorry that they were not able to talk about pain if they were in the 2 groups. They felt they were not good mothers, although the study showed them that if you don't say anything, it's better for your child. So the next step in the treatment is I persuade mothers, especially mothers, but also fathers, of course, they can't talk about pain for 4 weeks, not a single moment. And at the same time, I tell the children, which are in the same room, of course, as the parents are, that he or she can always go to his or her parents when they are in pain, and then the parents are able, of course, to give a painkiller or a massage or whatever they like to do. But especially the mothers are not allowed to talk about pain for 4 weeks. And then after 4 weeks, these children come back, and then I ask the question, so how were the 4 weeks? And then the children they frequently tell me, well, this was a very difficult 4 weeks for my mother. And it's sad, but at the same time, it's fascinating that it is. And this is what Lynn Walker showed. So these are the 3 simple first items I always do. Then there is a difficult thing, because many parents believe, and many doctors as well, that food is a very important factor for abdominal pain. So what we are doing now, currently in a new study, we take out lactose and we use a sort of low FODMAP diet. But I don't send them to a dietitian. I give a link of a website where the FODMAP diet is explained. And I tell them, don't do it too strictly, but use it as you like to use it. And I do this for 4 weeks. There's no results. There's no data in children at all. But I'm biased, but hopefully I'm wrong. But I don't think that dietary intervention will help children with abdominal pain. But again, many guidelines or many national guidelines, if there is a guideline, then they suggest you have to give more fibers, less lactose, less sucrose, or less fructose, or whatever. And then if it really works, then I tell them, okay, look back at the 4 weeks you have had now, and try to reintroduce food which you think your child is capable of taking. But this is my very practical way, without sending children to all kind of different people who have to treat them. So so those are the first 3 very simple steps, and you don't need anybody. And then we have a huge number of people who are educated now as full hypnotherapists. So many pediatricians and general practitioners are they like to send children to an hypnotherapist, but this is now for Holland, and we made a website where you don't have to see a hypnotherapist, but you can follow our website. That's also successful, which we showed in another study. But if it's not available, then I have no problem, because to send the children to a psychologist first, because there are good data about psychologists. Again, if parents don't like that, then the next phase will be a medication. And as you know, no single medical or compound has shown to be more effective than a placebo.
Yeah.
But I know from my colleagues from the United States, they are in favor of giving, for instance, amitriptyline.
Yeah.
And in some of the children, I do that as well. So that are the different treatments we are giving now.
And that's I mean, the treatment sort of plan that you described is very much what is done here as well, actually. In terms of, as you sort of talked about, I mean, in terms of, from my understanding, from a clinical perspective, I mean, childhood constipation accounts for a really large number of hospital visits, you know, in terms of in pediatrics. I guess for parents who are listening, you know, how do we define constipation?
We have these Rome 4 criteria, which focuses on frequency and consistency and consistency of stools. And then another important item is fecal incontinence.
Mm-hmm.
But some people in the world don't agree with these. I step out of this discussion. So I always use the Rome criteria, which, to my opinion, are very, very much okay,
Mm-hmm.
because they include all these different aspects of defecation.
Mm-hmm.
And so it might be the case that you can have a combination of withholding behavior and fecal incontinence,
Mm-hmm.
or withholding behavior and hard stools, and still have a defecation frequency of 3 or 4 times per week. So, but to my opinion, it's a combination of symptoms to define a child as being constipated. But you know, from birth till 18 years of age, the period we take care of children, you know, hard, infrequent stools and painful stools will define you as constipated.
Yeah. What are your, I mean, in terms of, I'm assuming there are organic and non-organic causes of constipation, so organic versus functional. What are some of the common causes of constipation that I guess the typical adolescent or child would experience?
Yeah, well, we of course don't exactly know why somebody gets constipation, but to reassure parents is that less than 1% of the children with constipation has an organic cause for constipation, and in a majority of those children, it starts within the first year of life. So what you mentioned is Hirschsprung's disease is then the most common cause of constipation. There are some children with anatomical abnormalities, but you know, the numbers are really, really small.
Mm-hmm.
So in the majority, the far majority, it's a functional cause, and the general opinion about the reason why children develop constipation, especially in the young ages, is just withholding behavior. Mm-hmm. And then there are some moments in life when children like to start withholding behavior is when you change from the breastfeeding to the formula, because then the consistency of stools for a short period change. So some people dare to say everybody who receives breastfeeding and then goes on with formula will face 1 or 2 days of constipation. So the far majority never develops then functional constipation, but you know, in a very short period you might have it as well. And in those children who really experience hard stools, then even babies start to withhold stools. And if you don't treat this within a short period, then you can get problems. The next phase, the next moment in life is when children should get toilet trained. Mm-hmm. Another moment in life is when children go to school. Mm-hmm. Then they start to withhold stools. Mm-hmm. And then there's the very complicated group of children who start to have constipation when they start to have their puberty, and most of them are girls. Mm-hmm. And we have no clue why these children develop constipation. It's called slow transit constipation. I'm always surprised that a girl who goes to the toilet once every 2 weeks, that you can't find any abnormality on colonic manometry, but it's true.
In terms of for listeners that might not get the difference, in terms of what is the difference between, say, I mean, you talked about slow transit. Is not all constipation slow transit? even if it is, you
Yeah,
know
yeah,
what I mean?
yeah, yeah,
Do you
yeah.
know what I mean?
Of
Like
course.
we hear slow transit constipation, and sometimes I have patients saying, "Well, I've been diagnosed with slow transit constipation," and it's like,
Yeah,
what is
no,
that?
you're correct. Of course, you're correct, because of course constipation is a slow transit through the colon. But there is a difference in, so if you measure transit time with, for instance, radio markers, or in Melbourne that work on scintigraphy, then in children, 80% of the children, you will find the markers in the rectum, and that's what we call outlet obstruction. And this, if you, there are not that many studies, but if you do a difficography where you put in contrast material into the rectum, and you ask the child to bear down, then you will see during this investigation that they withhold instead of relax their pelvic floor. So we think that the majority of children have an outlet obstruction. But if you do the same test in, for instance, these girls, then you will find that the markers, they stick everywhere. So in the left colon, in the right colon, and in the rectum, and that's how we define then slow transit constipation. But you are very clever, because you can say at the same time, okay, if markers are stuck you have a fecaloma in the rectum, which stucks there, then you can also imagine that it stucks higher up in the colon. I can't say anything against it, but in most of the children you will only see the markers in the rectum. So that's how we distinguish the two.
The way I see it or explain it is like a traffic jam. There's no exit. It's going to back up.
That's true. That's true. But the problem is, many parents recognize that these children withhold, and that's what we really define as outlet obstruction, and that's to my opinion, a major cause of childhood constipation.
Yeah. All right. So let's just say you've got a patient comes in, you've done again all the organic testing, and I'm assuming that when a child comes with, and I mean, I'm kind of curious, the testing that you do, you're not going to get them to do a manometry straight off the cuff, I don't expect. You'll be basing a lot
of.
Oh
no, but I have to tell you a secret. I hardly do anything. I listen to the parents. If they tell me that there's the most important question about in children with constipation is to ask about fecal incontinence, and then don't ask only about fecal incontinence. Is there fecal incontinence? Yes or no? No. But then you critically have to start questions about, okay, what time of the day? Is it in the morning? Is it several times a day? But especially is it during the night? Because those children who lose stools during the night, these are the most severe constipated children, and you don't have to do anything, because you know that the whole colon is loaded with fecal material. If I don't understand what's actually going on, then I only use the marker test. And then sometimes, as you probably know, you can be incontinent based on constipation, but there are also boys, mainly boys, who have incontinence without any other symptom of constipation, and these boys are only diagnosed with this marker test. And if the test is completely normal and you only have fecal incontinence after school, then you have the clinical entity defined as functional non-retentive fecal incontinence. And these children should not be treated with a laxative, because this aggravates the symptoms. So I do this test. I never do a colonic manometry test anymore, because it's too much work. It's too difficult to do in our hospital. It's difficult to sometimes to interpret what you see during the measurement, and our treatment is not based on the outcome of the manometry in the majority of children. Of course, we have to do a biopsy if we don't have one, but that's it.
Okay, so
and then of course parents are angry. Because, we're going to an academic hospital, and then you tell me all these stories, and you do this market test, but what else? And we want you to look in the colon, and I see I can't. It's of no use, because you only see shit. You don't see anything else. I never found a stenosis, so and then sometimes they're angry, sometimes they believe me, but nowadays in this very severe cases, I more and more do a barium enema to look at the configuration of the colon, and this helps me a lot, because in the last 2 years I found so many abnormalities with very elongated colons, with mega rectums I've never thought of. And then it makes the decision difficult, because then we have to decide if we take the colon out in some of these children, or only the rectum, or whatever. This is new. This is completely new. I have to think about it.
So you don't do an enema, like to do a clean out?
Oh yeah, I have no problem at all. So of course I like to treat these patients with oral laxatives. Yeah, I always try, and then I give high dosages of polyethylene glycol most of the cases, and then I combine it with bisacodyl or senna or magnesium, or with well, the drugs available. And then if you're not able to fix the fecal incontinence, which is most of the time the most terrible sign of constipation, then always in close collaboration with the parents, I start to do colonic irrigation. Mm-hmm. And so in the past I used enemas, which are in some children very, very helpful, and then but it's most of the time painful, and we find that colonic irrigation with these new systems are pretty good. Everybody's happy when the fecal incontinence disappears. The problem, of course, is there are not many data about colonic irrigation, so nobody knows how many days a week, for how long, when you taper the frequency. So this should be investigated in the future.
I mean, the thing that I was really looking forward to tell you the truth, was something that I don't really have an explanation for, and I wonder whether you do. So this is a really interesting topic, because we do see a lot of children who present to our clinic, the gut center, for fecal incontinence. Now, there's the group of children who, the parents are visibly able to see the withholding behavior. They need to go. They have the sensation to go. And then there's the other group where the child, and appears to be honest, reports not having any sensation whatsoever. What is, from my understanding, my theory, I guess, if you like, was when there's withholding, there's obviously a buildup of feces in the rectum can stretch, and the pressure receptors in the rectum can be, maybe damaged is not the right word, desensitized. Is that the reason that a child cannot have any sensation of incontinence? And even so, to the point where and then this is another question, is they can soil in their underwear and not feel it, and report not being able to smell it. Now that could be avoidance in terms of a shame factor associated with shame.
With long-standing constipation, who go to the toilet every week or every 2 weeks, they have a megarectum in most of these cases. And what we did using MRI, we showed with the rectal barostat that indeed these children have a different sensation than children who don't have these megarectums. So I think you use the right wording. It's probably desensitized or whatever. Something is wrong with the perception. So the stretch receptors in the rectum, they are only to give a signal to the child when the stool is so large that then the brain is able to sense this urge. So that's one. And then the second question is also a very nice question about the smell. And I have my own theory. I don't know if it's true, but for me it works. So I ask the parents always, do you smoke? And then they say yes or no. And then I said, okay, when you go to a party where people smoke, then you come in and then you say, oh, this is a terrible smell over here. What's happening? After 5 minutes, you don't know that this smell is there. And that's exactly how I think the children are. So they lose stools. Of course, they smell it. They act as an ostrich. I don't know if that's the good wording in English. So they know it's there, but they
Head in the
are
sand.
ashamed, or they don't want to know, or they neglect this feeling. But after 5 minutes, they don't smell it at all. So if you come into this room, then the child is not anymore aware of this dirty smell. But somebody who comes in can't understand that you don't change because it smells so much. So that's my explanation for how children, and I do honestly think that these children are indeed ashamed and neglect this feeling.
Yeah. Well, I was seeing a young child who had megarectum, and he had incontinence, and you know, it was really horrible for him. He tried a number of different things, and in the one of the interventions that they gave him was an appendicostomy, so a tube that goes through the appendix. So basically, he could flush out his bowel, and I believe there are other sort of procedures as well where they do the same thing as a way of managing constipation and fecal incontinence, etc. Are they things that your center does a lot of, or again, not necessarily?
Yeah. So first of all, we talk about a very, very small group of patients with constipation. So it's the far end of all those children. So I think it's less than 1% of all cases, because many of these children are treated by the general practitioner or the general pediatrician. We never see them. If you look back at your patients and they suffer from constipation for 5 or 10 years, and you give colonic irrigation, you give them laxatives every time, why do you wait for such a long time to help these patients? And I think that's a very, very good question, although difficult to answer, because your question is also, when do you do a surgical intervention, and what kind of intervention do you do? So some people favor to do it a Malone, appendicostomy, and I think that it only helps in those children who are helped by colonic irrigation through the rectum. So if you are successful in helping these patients and they are totally fed up with this kind of treatment because they don't like to stick it into their bottom, etc., then it is probably a very good way to use a succostomy in these children. Although you have to be honest, because there are many complications with this kind of therapy, because it can be painful, there can be leakage, all kind of things. But for children with constipation and spina bifida, it's perfect because it always works. But in those children with outlet obstruction, for instance, in functional constipation, in many times, in my experience, it doesn't work. So it's not worthwhile to do such an operation. So yes, in some children we do it. If in those cases they're fed up with their colonic irrigation and it's very, but in the slow transit constipation, for instance, I never do it because I don't find it favorable.
Marc, thank you very much for your time.
I think it's very nice that you called an old friend in the Netherlands to talk about shit.
It is all pretty much shit talk that I do in the talking gut. After all, that's what a big part of what it does, isn't it? Thank you again, and I really look forward to seeing you in person, mate. We can have another beer.
Okay, thanks, Jim. Bye.
Bye.